let's say hello for everybody once again. So, and now, today we have a class of basic and clinical pharmacology. Our today's chapter is actually the diuretics part. Now let's continue with our chapter in here. Diuretics. What are the diuretics now initially? Let's talk about now. Previously, what did we discuss in the previous lectures? In the previous lectures, we were discussing about the cholinergic pharmacology. Now, cholinergic pharmacology, the receptors, agonists, antagonists, mechanisms of action, what type of effects do they have, what what type of mechanism of action, where they are located, what type of tissues are in there that they have muscarinic and nicotinic receptors. We were considering them too, but today we are going to discuss about the diuretics. Now, the diuretics chapter is actually related with urine. Now, urine is going to be in an increased way. So, in order to decrease the amount of fluid that is found in the blood. So, these are called as diuretics. These type of drugs names are diuretics. Now, there are many different, there is a classification of diuretics too. So we will be discussing about main parts that these diuretics have. Initially, we will be talking about the osmotic diuretics. Okay, so and after that, we will be considering about that carbonic anhydrase inhibitors. They are also considered as the diuretics in a diuretics class. And another one, we'll be considering about loop diuretics too. But about the thiazide diuretics, and thiazide diuretics, if we have time, let's come to our diuretics. You can turn your microphone and some sounds are coming. And in order not to be disturbed by the sounds, we can turn them on off too. So if they do not turn off, let me turn them off by myself. Now let's continue here, guys. Diuretics are well known. Now these are the drugs which may result in mostly the side effects are these two, the most important side effects. What are they? These are the hypocalcemia and alkalosis. What is the hypocalcemia actually? Hypocalcemia, coming from the word of kalium. Kalium is potassium, as you may remember. Kalium is potassium, and the amount of potassium is going to be decreased too much. So why it is going to decrease? Because the amount of potassium is going to be excreted via the urine, and so the urine it will be going out of the body. And what about the alkalosis? Alkalosis is a condition where there will be a hydrogen plus ions are going to be removed. So it means that there will be an increase in the pH. And if the pH is going to be increased, there is going to be an alkalosis. But what about if the pH is going to be decreased? There is going to be an acidosis occur. Lower the pH, it means that higher the acidity is going to occur, as we know from the general chemistry too. Now, diuretics blocking sodium plus reabsorption above collecting ducts increase sodium plus ions, lower to collecting tubules and ducts downstream, increasing loss of potassium, leading to hypocalcemia. This was the part that we have considered. Now, actually, now diuretics are all related with our nephron cell. Nephron and these are the cells, as you know, found in the kidneys. Now, their function we have already learned in the biochemistry of kidneys, chapter 2, that they have the filtration functions. Now it will be filtrating the blood now, and the toxic substances are going to be excreted out of the body, and what will be going on? And there will be a reabsorption of sodium and potassium, another one chlorine substances to bicarbonate ions, reabsorption to hydrogen plus ions, reabsorption to all of these substances, ions are going to be reabsorbed too, but not all of them, and some of them in some different areas. There is going to be a reabsorption of certain types of ions, like sodium and chlorine, for example. But for example, in a descending loop, as we know, there is the structure of Nephron cell. Now let's show you the structure. I did not show you in there too. Let's come to that part actually. These are and this is the structure of nephron cell. Now, what happens in the nephron cell? There is the glomerulus now, and the arterial hole, afferent arterial hole is going to be interacting with this glomerulus area. So what happens is in here is that the blood is going to be entering through this part, and it is going to be filtrated. Now, bigger molecules such as proteins, now erythrocytes, and another type, and any different types of serum albumin and other different types of proteins are going to be they are not they are not able to pass through the holes of these glomerulus. Only the substances which are very small in their size, only these are going to be passing through these glomerulus. Now, after passing, there is in the spatial regions of the nephron cell, and this is the proximal convolutional tubule. Now, after passing through the proximal convolutional tubule, actually, let's talk about it too. There will be an absorption of sodium, chlorine. Another one, there will be an absorption of bicarbonate ions, reabsorption, I mean. Reabsorption means what? Now, blood is going to be passing through this area, and from this area, the substances which were actually filtrated are going to be reabsorbed back to the blood. Like what type of substances? Bicarbonate ions, sodium ions, chlorine ions. Water is going to be also reabsorbed back to. But and in here, this is the cortex area of the nephron. And there is also the medulla area too. Now, a loop of Henle is actually located in the medulla part. Now, when it will be, and when the glomerular filtrate is going to be downwards, and there will be there will be a reabsorption of water in there mostly, because there are some permeable membranes. These membranes are going to be excreting now out only, and water are going to be passing through these membranes. But another substances like sodium and chlorine ions, they are not going to be passed through these membranes. Now, this is osmotic condition, by the osmotic pressure. There is going to be a water reabsorption too. Now, after that, and this is this thin descending loop. And after that, there is also a loop of Henle, and this part is ascending loop of Henle. Ascending loop of Henle is going upwards, as you may notice in here. Now, this is the thin ascending loop and thick ascending loop too. There will be there will be a reabsorption of sodium plus ions too, but mostly here, this area outside of this loop of Henle is actually very rich with sodium and chlorine ions too. Now, water is going to be excreted out in order to balance in order to balance the concentrations too. And sodium is also going to be excreted out, because the concentration of sodium in here is going to be really increased. So in order to balance that, there will be an excretion of sodium ions too. After now sodium in a thick ascending loop, there will be an excretion of sodium plus ions, chlorine minus ions too. And here we have distal convoluted tubule. Distal tubule, in other words. In a distal convoluted tubule, there will be also the release. Now there will be a reabsorption of these calcium, magnesium ions. We will be talking about loop diuretics, and after that, related with hypocalcemia and hypomagnesia, and we will be talking about these terms too. Now, and there will be also a reabsorption of sodium ions, chlorine ions, calcium in there, aldosterone, and after that, it will be passing through the collecting duct. In the collecting duct, there is also a reabsorption of these substances as ADH hormone, another one, water 2 and urea 2. And after that, it is going to be entering urinary bladder. Now, and these are all that we have. This is all the parts of the nephron cell. Calcium now, carbonic anhydrase inhibitors are located in the first part. And these are the carbonic anhydrase inhibitors. And second part are the osmotic diuretics. Osmotic diuretics will be acting on this area of the nephron. Another one is the loops, actually. These are the loops, loop of Henle, ascending loop, descending loop of Henle, ascending loop of Henle part, thin part and thick part too. Another one, thiazides act on the number 4 area. These are the thiazides area. Another one, potassium ion sparing. It will be acting in early collecting duct. Another one, early collecting duct, and aldosterone is also aldosterone antagonists are also act on early collecting duct too. Aldosterone, here we have. Their site of actions are also written in there too. Now let's come back to our main chapter here. Now, actually, this part is not important here. Let's come to osmotic diuretics. The first one is actually the osmotic diuretic. And the osmotic diuretic, which is the most important one, is mannitol. Mannitol 4 inhibits water reabsorption throughout the tubule. It increases urine volume. And in all the diuretics, it will be increasing the urine volume too. And what type of uses does it have? It also has the use of decreasing of intraocular pressure in glaucoma. For the patients who have the intraocular pressure increasing of this intraocular pressure, the fluid in aqueous humor is going to be increased in that in this condition too. So it will be stopping the. So if the carbonic anhydrase is going to be it's not actually related with carbonic anhydrase. It will be stopping the release of aqueous humor production in the eye, which will be decreasing the intraocular pressure. Another one, intracerebral pressure is also going to be decreased too.
Excuse me,
another
sir.
name for it is as intracranial pressure is going to be decreased too. So another one, there is oliguric states also can be used for the oliguric states as osmotic diuretics, like for example rhabdomyolysis. Now about this disease, this is actually really now dangerous disease too. And now what will be going on is, and there will be myo coming from the word of muscle, and lysis is going to be breakdown of the muscle. Now the muscles are going to be broken down, and they are going to be entering through the glomerulus, and they are going to be now this myolysis. it means that myosin is going to be found in in the urea. Actually, in a healthy people do not should not contain any of the proteins or any of the proteins in their urine. If they have a urine, they have very serious troubles. The color of the urine is going to be also changing too, like the color of the Coca-Cola. As you know, the color of Coca-Cola is really dark, and when they are urinating, they will be able to see really dark color of the urine. This is called as rhabdomyolysis. And for the treatment of it, there will be a usage of osmotic diuretic like mannitol. Another one side effect of it is actually acute hypovolemia. Now, what about the hypovolemia? This is the condition where there will be in the blood there will be a really high decrease in the concentration. Now, in the amount of blood actually. Now the amount of fluid which is found in the body is also going to be decreased in that way too, and this is called as hypovolemia. Now, clinical correlate about this osmotic diuretics. These are they are contraindicated in cardiac heart failure and pulmonary edema because they draw water from the cells and increase the filling pressure of the heart. So for those who have heart failures and pulmonary edema, it is not actually used as a receipt too. So you should, the doctors do not write them as for those patients who have this type of diseases, because it will be making the condition of the patient even worse. Okay. Now, let's come to the carbonic anhydrase inhibitors. Now, carbonic anhydrase inhibitors are actually, and these are the substances which inhibit or which block the activity of carbonic anhydrase enzymes. There are different types of carbonic anhydrase enzymes, but we will be considering here only two of these types of carbonic anhydrases. Now, this part is actually luminal membrane part. What does it mean? Here, there will be a glomerular filtrate passing through. This is the proximal tubule. Now, proximal tubule and cell, okay, this is the cell, epithelial cell of proximal tubule. And this part is urine part, and this part is outside of the proximal tubule part. It is considered as the blood part. Basolateral membrane after this area, this part is, and there is actually a blood. Now, inside of the urine part, there will be what type of actions will be occurring in there, and the acetazolamide, and this is the drug used as carbonic anhydrase 2. Now, what does it do is it actually will be blocking these carbonic anhydrases. So by blocking it, now initially, let's talk about the mechanism in a proximal tubule. In a proximal tubule, there will be a sodium and plus ions, hydrogen plus ions, and now sodium is going to be entering into the cell, but hydrogens are going to be going out of the cell. So there will be a sodium plus hydrogen plus anti-transport, and so and there will be a reaction of these hydrogen plus ions together with bicarbonate ions in order to form carbonic acid. This carbonic acid is not stable in here, so it is going to be converted into carbon dioxide and water by the help of this our main enzyme, carbonic anhydrase enzyme. Now, carbonic anhydrase, after the formation of carbon dioxide and water, these two substances can easily pass through this membrane, and so they are going to be passing through, and because they have some now carbon dioxide has nonpolar property. So nonpolar substances can easily pass through the cell membranes, as we remember. Now, after passing through, there inside of the cell, there is also another carbonic anhydrase 2, which converts them back to hydrogen plus ions and bicarbonate minus ions too. And hydrogen plus ions are going to be reversed back. They are going to be entering the urine part to luminal membrane part, lumen of the nephron. And but what about the bicarbonate ions? Bicarbonates are going to be released out by what? There's a sodium also is going to be released out of the cell too, but potassiums are going to be entering to the cell. And bicarbonate, now carbon dioxide and water can also be excreted out to the blood too. And in here, because they can easily pass through too. Now, so here is also important thing, guys. If the carbonic anhydrase is being blocked by the acetazolamide, this is our main drug. There is also another drug. Now, the drugs of carbonic anhydrase inhibitors are actually contain zolamide, zolamide, what suffix of the word, zolamide. They will be ending up with zolamide. Now, and there is another zolamide too. We'll be considering about it after some time. So the main action of it is blocking of these carbonic anhydrases. If the carbonic anhydrase is being blocked, it means that there will be no conversion of bicarbonate, now carbonic acid, into the carbon dioxide and water. So what will be resulting is, and there will be these substances, these acids, are going to be excreted out too. Now acids are going to be excreted. And this is the urine part. Urine is going to be excreted by entering the bladder, urinary bladder. Another one, now actually, and another one here is calcium, no, not calcium, carbonic anhydrase inhibitor, which will be stopping, also being inhibited too. When there is an inhibition of this carbonic anhydrase, there will be no formation of hydrogen plus ions. It means that there will be no there will be a decreased amount of now in acid concentration. It means that there will be an increase in pH. An increase in pH results in what we have already learned. Main side effects of the diuretics is the one which is hypocalcemia, and alkalosis. We have this type of parts. Okay. Now let's move on here.
Excuse me, sir.
There will be a decreased amount of hydrogen plus ions, which will be resulting in an increased amount of hydroxide minus ions in later on stages too. So the blood is going to be having what type of pH? Increased amount of pH, which could result in alkalosis. Alkalosis is a condition with higher pH. Now, let's come to our main our main drugs of here we have. These are the drugs of carbonic anhydrase inhibitors. Acetazolamide was one of them. Second one was dorzolamide. Mechanism of them is actually here we have hydrogen plus formation is going to be decreased inside of PCT cell. Sodium plus hydrogen plus antiport is going to be also decreased too. Sodium plus ions concentration is going to be increased, and bicarbonate ions are also going to be increased in the lumen part, and diuresis is also going to be increased. Diuresis is higher amount of urine in the bladder. So uses for the glaucoma, acute maintained sickness, metabolic alkalosis also too. Now, Let's continue here. Side effects of it is carbonaturia and acidosis, hypocalemia. Another one, hyperchloremia, paresthesias, renal stones. Renal stones can be formed from calcium phosphates in there because of low alkaline conditions. Now really high alkaline conditions would result in the formation of these stones, in the stones which are actually formed from calcium phosphates because of the alkaline medium in the nephron cell. Sulfonamide hypersensitivity can also be used in there too, as now these are the side effects of them too. Now, what about the loop diuretics? Loop diuretics actually, let's talk about the mechanism of action of this loop diuretics. In the loop of Handel, in a thick ascending loop of Handel, there is what? Now this part is urine part, and this part is the blood part. This is the epithelial tissue. Urine, this is inside of a nephron cell. And what will be going on in there is chlorines and sodium plus ions, chlorine minus ions, sodium plus ions, potassium plus ions are going to be entering and inside of the epithelial cell. This is the cell in there, which will be resulting in what? When there will be a higher concentration of these substances, potassiums are going to be going backwards too. Now this is the potassium. It is going to be now flowed away into the urine part to back. Okay, when there will be a potassium flowing out, there will be a potential positive potential will be occurring in there. Now the urine becomes a little bit positive. Now, do we need this type of condition? And do we need a higher amounts of positive charges in the same place? No, we do not need this kind of condition. So in order to balance this condition, this positive charge, another positively charged ions are going to be excreted out. What type of another ions? Magnesium plus ion plus 2 ions, calcium plus 2 ions are also going to be excreted out. So, but what about the loop diuretics? What do? They are going to block these channels, these parts, which will be transporting chlorine, sodium, potassium ions together. So if there will be a blockade of these parts, blockade of these transporters, there is going to be there is no change, and there is no positive potential occurring, because potassium also will not be flowing out of the cell too. It means that these are all the substances are all going to be excreted out via urine. So it means that calcium levels are going to be decreased, magnesium levels are going to be decreased because they are going to be excreted. They do not enter blood. They do not enter to be excreted from the body. It will be resulting in hypocalcemia. Hypocalcemia is the condition with lower amount of calcium. This is the mechanism once again. Sodium, potassium, chlorine transporter inhibition is going to be occurring in there. And actually we just have talked about it, and we can continue in there too. The uses of this is actually, and it can be used in acute pulmonary edema, in heart failure, in hypertension, refractory edemas. Another one, anion overdose, hypercalcemic states too. If there, let's say, if a person has really high amount of calcium, what needs to be done? He can actually take these drugs and he can decrease the calcium level in the blood too. What about the sulfonamide containing drugs? Sulfonamide containing drugs have close allergenicity with carbonic anhydrase inhibitors. All loop diuretics, and now actually, for example, sulfonamide containing drugs may have allergenicity for loop diuretics too. Now, for example, but instead of these sulfonamide containing drugs, they may use ethaclinic acid. Ethaclinic acid is also used as drug too. So as what? In order to avoid this allergenicity symptom too, okay? Thiazides can also be used, can have allergenicity too. Another one, sulfa antibiotics and celecoxibs. Now this about the side effects. And sulfonamide hypersensitivity is the side effect. Hypocalcemia and alkalosis, this is the main side effect, as you may have noticed too. Hypocalcemia, hypomagnesemia, hyperuricemia, the increased amount of urine, ototoxicity. Another one, drug interactions would be considered as aminoglycosides, enhanced ototoxicity, lithium, chronic loop administration, and decrease in clearance, digoxin, which increases the toxicity due to electrolyte disturbances too. Actually, that's it for today now, everybody. Take care of yourself.
Take care too, sir.
Very nice.